So what Maurice and I are trying to do with this regional COVID-19 model is we're trying to democratise these models. I mean, members of the public all over the world can watch the news and they hear their politicians talk about the policies that they're following, and they hear their scientific advisors are telling them what to do. But those members of the public can't see any of this. They've got no access to the models, they don't know what they do, and they certainly can't understand how those models relate to their particular circumstance. So our model starts from recognising that disease outbreaks are regional or local in character. If you take a whole country, unless that country happens to be pretty small and well bounded, it's not good enough to take an average across that whole country. It could be quite a large region, like London, like Hong Kong, like New York. A case we've particularly worked on is Jakarta. Or it can be smaller regions and local areas like, let's say, Oxford in the UK, or small town US, or maybe an island situation like Crete, or a city like Medan in Indonesia. Now, not only is the disease outbreak itself regional and local, but the healthcare system is also organised on a regional and local basis. Hospitals serve their local conurbation and the surrounding hinterland. So what this means is that policymakers really need regional insight in order to come up with policy appropriate for that region. And the citizens in those regions actually deserve an accessible and transparent picture of what could happen in their regional, their local area, and why that is likely to happen. What do we mean by a region? Well, basically, it is that the daily traffic in or out of that region is small relative to the mingling that goes on among the population in that area. This is quite difficult in some cases. So London, for example, obviously has a very heavy daily commuter traffic going quite a long way out. Now, how have we tried to make this model useful? Well, the first thing is it is totally accessible for everybody. Just go to that link. You don't need to install anything. It'll just load in your browser. You can run it in the next minute or two. We've made it as easy as possible to set up for any region. You just add the age group distribution for that area. Optionally, you can put in the number of hospital places and ICU places that serves that area. That's just to see whether the active cases that come out of the model hit up against the kind of limits that you've got for hospital capacity. Now, we do recognise that local details can be extremely varied. So, for example, the model uses mortality rates that are pretty typical for developed countries, but if you're working in a very impoverished part of the world, you may want to adjust those mortality rates. You might want to adjust the social contact rates that are in the model. If you happen to be in a situation where the population is extremely dense and they bump into each other a lot, you may want to ramp up that social contact rate, for example. And you can easily adjust the imposed policies, what's happening in your area in terms of social distancing policies. Is it extreme lockdown, or is it something a bit less than that? Are there policies in place to improve on hygiene, for example, such as wearing masks? Now, when you've done that, the model plays out on charts that you can easily understand the changes that take place to the daily rates of COVID cases, the deaths that occur, and the recovery rate. And the model allows you to compare those with publicly reported data, recognising that that publicly reported data is very often incomplete and understates the reality of what's happening. And we hear politicians and their advisors talking about this R0 thing and the R thing, which is to do with how many other people each infected person passes the virus onto. The model unpacks that in a very transparent way, so you can see all of the parts that make up those ratios. And that's important. Not only so you can see why the model's generating the results that it is, it also means that you can assess policies that attack each part of that. Policies, for example, that remove vulnerable people from the likelihood of being in contact with infected people. Policies that reduce social contact rates. Policies that reduce the likelihood of any contacts resulting in the virus being passed on. And in all of this, the model is totally transparent. Every single assumption is there right in front of your eyes. If you don't like it, if you've got better information, you're very welcome to adjust it and see what difference it makes to the model's results.